So we're talking about the pelvic floor, which is not familiar territory for a lot of occupational therapists. I find that as an OT that's been practicing for 20 years, although I did spend the first 10 years in early intervention and very, young children below the age of 18, it's something I probably should have been more in tune with, but it just wasn't something that was really on my radar until recently, really in the last couple of years. As an OT now working with the adult population, mostly geriatrics, pelvic floor is something that is very intriguing to me. It's not something necessarily that I want to become specially trained in, but I do feel that there is some very basics that clinicians like myself should know and should be educating ourselves on for two reasons. One, to recognize the issue that a patient may have, and two, to have just enough knowledge to get them started if you are in home care, to give them some tools to start using, some exercises to do to see if they can try to start making any changes and noticing a difference at all, and then you refer them to a specialist. In home care, our patients obviously are homebound, so getting to outpatient, if there is still a rehab goal, is always the main goal. But for some people that may not ever happen. Maybe there's not a pelvic floor therapist available in your area at all. I am finding that they are very limited as far as availability, and their wait lists are pretty lengthy. You have to be referred by usually a urologist or your primary if they know enough to refer you there. And you could be having a patient wait sometimes 3 weeks to a month before, or if not longer, to get in. So knowing a little bit helps an awful lot. So 100% truth here. I didn't know much about it at all until last year, but here's where I found myself looking for more information. I frequently, obviously with geriatrics, you're dealing with incontinence, urinary incontinence, both men and women. And we all know the traditional Kegels, right? Everybody Kegels. But what happens when you can't even perform a Kegel? So I kind of started looking information up about this. How do you get things going there? What are your options? And why was I doing this? Because with the OASIS changes that were happening last year and with our training, it became a question and a risk factor. Incontinence is a risk factor for falls. It makes sense, right? If you can't control your bladder and you're in that stage where you know you've got to go and your mobility is limited and you're trying to get to the toilet and you're rushing to get on that toilet and you're trying to get your pants down and you're losing control, you can do some unsafe things. If your balance is off, if you're trying to manage a walker, get your pants down and you're leaking urine the whole way, man or woman, you're at a high risk for a fall, right? So obviously I'd known that, but when it became a thing on the OASIS as far as scoring criteria and risk for falls, I really saw an opportunity as an occupational therapist to do more to help my patient in that area. Occupational therapy is constantly dealing with toileting, clothing management, toilet hygiene. We work on functional mobility related to ADLs, right? So the mobility that's required to do the toileting task, the balance that's required. So I looked a little deeper and thought, well, what about exercises to help with that? Now, as I've discussed in previous podcasts, exercise and documenting progressive resistive exercise in some form of a home exercise program is very important in documentation for Medicare and insurance. You need to be showing progression. So sometimes it's hard to find exercises or to list exercises that are appropriate for a patient, especially if one of their main issues is this, toileting. So I found myself digging for information. I took a great online course through Summit Education, and I have they have a great option on there where you can pay a flat fee and have 1 year's full access to all their recorded education seminars. So they're all video recordings, and you get all the documentation, all the what do I want to say, like the paperwork that goes along with it as well. So I took a really great one on geriatric related pelvic floor. And I'll put the link in the show notes. It was just very informative and helpful, and a lot of exercises were given, very easy functional exercises that you could do. Now, she's a trained pelvic floor therapist. She was a physical therapist that provided the training. And as I said at the beginning, I am not, and nor do I have really the interest in becoming certified in that area, but taking continuing education to learn more about it is really, really useful and helpful. So I'm going to use my few minutes here to kind of go over this with you guys, because if you're like me and you work with a geriatric or adult population that struggles with incontinence, I'm sure you have felt that kind of like you're a little bit at a loss. Beyond recommending the toileting schedule, right? Timed toileting, voiding practices, getting up in the night, setting an alarm. We all know the drill, right? This is how you avoid the full-on incontinence issue, along with different ways to manage incontinence equipment. So like the pull-ups with a pad inside so that you don't have to, change all of your clothing if you have an accident. So we all know these tips, right? Now, what if you could just go a little bit beyond that by starting your patient with some really basic exercises that they could work on their own, and within a week's time, a week to 2 weeks time, you hear from your patient that they feel that they're making some progress. Perhaps they're not getting up in the night 4 times to go to the bathroom because now they can empty their bladder. So I'm not going to go through a super detailed thing here, because I encourage you to find the resources, maybe take an in-person class or an online class where you learn hands-on yourself from a certified specialist. I'm just going to give you some of the tips that I have found useful and why it's useful. So first, let's start with this. I find a lot of my patients, especially over 60, with other comorbidities, to have decreased mobility, right? They sit a lot, they're not moving around. So if I ask the incontinence question and I find that they are struggling with incontinence in one of 2 forms, right? So there is stress-induced incontinence. Well, there's really 3 big areas here. Stress-induced incontinence, full-on incontinence, can't manage it, don't even know it's coming out. I'm wet all the time. I stand up, everything pours out. And then there's this other issue of inability to void. So I feel like I gotta go to the bathroom, I gotta go, I have the urgency, they get to the bathroom and nothing happens. Then they get up, they're standing up, they're pulling up their pants, and stuff is dripping out. And I have found myself in the past, like, I don't really know what to tell you. Maybe you should drink more water. Like, I always have like these really random, I used to have these kind of random suggestions, but I wasn't feeling very helpful. So now, what I do is I see patients and I ask about the incontinence. And when I find that there is an incontinence issue, I ask them to, hey, can you try something for me? They're sitting, and I don't know if you can see me, and I'm in the, for those of you listening to a podcast, this is also on YouTube. So I ask to see if they can move their pelvis for me. All right, so they're sitting still. Can you tip your pelvis forward? Can you tip your pelvis back? Can you lift one side of your hip off of your seat, or a little bit off your seat? Can you lift your other one? That right there tells me an awful lot. You'd be surprised how many people, when you ask them to tip their pelvis forward, there's nothing going on there. They will lean all the way forward. They're trying to move, but their pelvis is not isolating, right? So what does that tell me? With my clinical assessment, looking at that, there are some weak trunk muscles just in general right there. There's also poor proprioception in that region. Those contribute to a lot of things. Can I make a difference with that? Can I help improve that? Most definitely. So I look at that. then I ask, I want you to do this for me. I want you to sit in a relaxed position. I like to be able to see their lower belly. And I ask them to blow out of their mouth, like they're gonna blow out a candle. Okay, so blow out of your mouth, and I'm watching their lower abs, right? And sometimes if they are, they're kind of overweight or rotund or whatever, I'll put my hand on their lower belly so that I can feel it. My dog is in here with me. If you hear her barking, I'm sorry. So I put my hand on on their belly, and I ask them to blow out, right? So they go. You should feel, and they should feel, their lower abs, which is actually your transverse abdominis, start to contract and hold the contraction. So they can blow and hold that contraction. Oh, good. Okay, I make them aware of that. Do you feel that? Hey, would you like to work on that muscle a little bit? Because if we can start there, you're going to start being a little bit more aware of your pelvic floor. Then I explain their pelvic floor to them as simply as I can understand it. And it's like this. Your pelvis, imagine it like a bowl. Your pelvic floor has muscles all in and around it. And so if we can sort of wake up that area a little bit and give you more control over it, you may start to notice an improvement in how you control the flow of urine. And that includes being able to empty your bladder. So some of the most basic things that we start with is that if a person cannot mobilize their pelvis for me at all, they're not getting any anterior tilt, there's no lateral shift going on through the pelvis, you can do two things. You can get a towel, and you can have a rolled up towel for them to sit on, sort of kind of almost like a tube, right? Like a fat tube that they're going to sit on. Like a bolster, but it's softer, right? Or I'm going to show you one of my favorite things that you can order or pick up somewhere that's inexpensive. It's a balance disc, right? So you guys may have this in your gyms that, if you're in short-term rehab, but pick it up. So a balance disc like this, right? You don't want to have it overinflated, but it should have some give to it. And what's going to happen is this. So currently, if you're watching this on YouTube, I'm moving my pelvis, but I have good ability to move my pelvis and keep my upper body still. Watch what happens when I sit on the disc. Okay, so I'm sitting on the disc. Okay, I can tip my pelvis so much more forward and rock it so much further back. And side to side, my hip can drop way down, much more so than if I'm sitting on a flat surface. So I like to bring these in to the patient, maybe the second visit, because obviously I'm not going to carry this into the evaluation, not knowing what's going on, and have them sit on that and start to be aware of their pelvis. Okay, so who out there is going, oh, this is PT. It's your trunk. It's your... Yes, correct. This is also addressed by physical therapy. So talk to your teammate. If you have a physical therapist who is working with this patient, tell them that you are concerned about the incontinence issue for all the reasons that you may be concerned about it, and talk to them about what are your goals, what are you going to be working on? Are you going to be doing trunk strengthening exercises? Could you put these few things in there? Do you know about pelvic floor? Could you do a little bit of that? If the PT is like, oh, I got my hands full, I'm working on range of motion, standing balance, weight shift, whatever, you guys work that out together, right? Okay, so let's assume everything's been worked out, and guess what? You're going to be working on this with this patient. Get excited because you're going to see a change. And I encourage you to do this yourself. Let's say that you have no issues whatsoever, right? You've never sneezed and had a little dribble. You've never had to go to the bathroom so bad that you see the toilet and you feel like you're gonna explode, right? Okay, then you have no idea what I'm talking about. But I'm pretty sure that might be less than 1% of people watching, because I know as a mom of 2 that frequently happens to me. And I have found these exercises, these simple approaches, to be so, so helpful. So I want you to try them too, and I encourage you to not only take the class, but also, or find a class that you want to take online or in person, but research also other specialists and do some of these exercises. But these are the basic ones that work for the geriatric population that can't necessarily be doing big floor movements. So we're going to start with the pelvis. We're going to start by asking them to exhale, blowing out, activate their lower abs and feel that change, right? Then we're going to ask them after they've done, I usually have them do like 10. Let's do 10 and really focus on what's happening with that muscle. I have them put their hands there. How does that feel? They usually tell me, yeah, I can feel that. If I feel a tension in there, it feels tighter. I'll start that very first day by saying, this is what you're going to do. You're going to do those exercises twice a day. You're going to do 10 reps twice a day. Okay. If I feel like they can do more, the next thing that I'm usually going to ask them to do is either to sit on a towel, or if possible, some form of a balance disc. And I'm going to ask them, I want you to work on tipping your pelvis forward as if it were a bowl and you're emptying the water out of the front of the bowl. And then I want you to breathe regular. I don't want you to be tense. I want you to relax. I want you to be aware of where your pelvis is. Put your hands on your hips. Then I want you to tip your pelvis back like you're trying to keep the water from falling out, and maybe even tip it out of the back of the bowl. So without asking them specifically to pull their navel in or use certain muscles, guess what? By moving your pelvis this way, you have to use those muscles, and they feel successful in it. Now, all the patients that I've worked with doing this, I want to say 90% of them, the very first time I ask them to move their pelvis, they cannot do it. They have no idea what I'm talking about. I put my hands on their pelvis, I move their pelvis forward, and it can be a struggle just for me to manually put them into a anterior tilt. But after they do a few of these exercises, either sitting on a round towel roll or a balance disc or even a pillow, they start to be able to move their pelvis. And over a course of even one day, they notice a big difference. So this is the goal, right? You want to increase proprioception of the area. You're at the same time activating the muscles that control your pelvis. So I'm not going to get too detailed with the patient about what's going on in their pelvic floor. I just want them to start moving those muscles a little bit. So the next step usually for my patients at this phase, I may come back, the second visit, the third visit, I take a look at how much are they moving and am I having to physically assist them to move their pelvis? How many times can they do it in a row? And I'm watching. I want you to keep your upper body still, really isolate your pelvis, stay relaxed. We're going to work on breathing. As they move, let's say you're pulling your pelvis back, right? So you're tipping your pelvis back. Then on the second visit, I'll say, now we're going to focus more specifically on exhaling. And I want you to blow out of your mouth, and I want you to think about your belly button trying to reach toward the back center of your spine. Behind to right, straight back behind it, like there's a cord going back there. You're trying to get those parts to mix together, but blow out. And I don't want you to use your legs. I just want you to blow and imagine your belly button trying to get like a magnet to the back side of the pelvis. You'd be amazed at 10 reps of that, my patients are tired. And they are like, wow, I really feel that. Great. Okay. Can we do a little bit more? Are you up to doing a little bit more? Let's look at tipping left to right. So now I ask them to lift let's say your right hip. Lift your right hip towards your ribs. That is a good cue. It usually helps people understand what I'm trying to say. Keep doing that. We're gonna do that and blow out. Hold it there for a second. Okay, now relax. Shake it all out, relax. Repeat it. Bring your pelvis, the top of your pelvis to your hip without using your legs, and relax. Okay, so now we've got some obliques going on, right? Am I really trying to strengthen their obliques? Would I write that in my note, strengthening person's obliques? No. In my note, I'm going to say, utilizing pelvic lateral tilts to increase proprioception of pelvic floor musculature increase ability to control urine flow, awareness of, you could say however you want to word it, everybody's wording is the same, but you're not going to say necessarily, I did 10 oblique exercises. You can say that you utilize oblique activation with pelvic mobility, with hip hiking, you can say, or however you want to put it, in effort to increase patients' proprioception to the pelvic region for incontinence training, right? We're working on incontinence training. You don't have to get super specific. You do need to state why you're doing what you're doing. So that's the next thing that I do. I have these patients work on this on their own, and with everyone I've worked with, they have noticed a difference within a couple of days as far as the ability to control the flow, right? When they get to the bathroom, it's not pouring out, or they can hold it just those few extra seconds. So the other thing I ask them to do is when you're going to the bathroom, see if you can stop the flow. I just want to see, can you or can't you? Just try and then tell me what happens when I come back. And then we kind of use that as a marker. Are you more able to control it? Those types of things. One example, I have a patient who has, I'm drawing a blank. She has an inability to void, so retention due to stress. So she gets anxious. She feels like she's got to go to the bathroom. She can't empty her bladder. I remember one time she was trying to get a urine sample for the doctor, and she just could not. Half a day went by and she could not collect a sample. The simplest trick worked for her. So she was thinking about it too much, right? She's all stressed out. Everything's tight down there. So bladder isn't releasing, urine. It's not flowing through the way it's supposed to. So I told her, just sit on there. Let's move your pelvis around. You're sitting on the toilet. I'm literally sitting with her at the bathroom. She's sitting on the toilet. And I'm like, let's move your pelvis. So just relax. Okay, let's blow out. Let's relax. That worked. Tried to go, couldn't go. Okay, let's just partially stand up now. So think about this for people who have retention issues due to stress. So have that person partially stand up and do a light cough. When you cough, typically, if you're going to have leakage comes out. This increases the awareness, right? She was thrilled that this allowed her not only that time to get a urine collection for her doctor, but other times when she felt like, I really got to go to the bathroom, but I can't, it won't come out. Knowing how to move her pelvis really made a huge difference for her, because she was able to somewhat kind of manipulate the bladder just enough that then the flow would go. And then it would get to a certain point and she could cough, and then the muscles that are tense would have to sort of relax and let it flow out. And it was successful for her. Now, why is this important? It's important because if a person is constantly trying to go to the bathroom and they can't void fully, they're going to go back and forth to the bathroom. And in this patient's case, she was constantly fatigued. And she was a high fall risk because of sort of a neurological thing going on, like a Parkinsonian type gait. So every time she went to and from the bathroom, it was an increased risk for her. So how do I minimize that fall risk? I minimize it by cutting back the number of times she's going to the bathroom with this anxious state. So make the most out of the time you're sitting on the toilet. Let's really figure out how you can empty this bladder. She was successful with this. She was successful with her attempts to void her bladder by using pelvic tilts, anterior, posterior, and lateral. And then a little bit of a cough and some deep breathing. It worked every time. So now she has a strategy going forward. Anytime she's feeling that, she remembers, I got to try these tricks. If I can at least get some of that to come out, that's good. So that works for stress-induced incontinence or retention. It works for helping people to control it, right? Being more aware of what's going on down there, really tuning in. There's a whole lot that's going on. There's nerves going through there. There's a small muscle that the instructor in the course that I took explained so well, that it's just when that is activated, or if it's tense, it's constantly sending messages to the bladder. You gotta go, you gotta go, you gotta go. when actually you don't have to go. So in some cases, you really need to relax some of these pelvic floor muscles. They're strained, they're stressed, they're tight all the time. So if you think from a neuromuscular standpoint, if I'm, let's say, trying to get shoulder range of motion for some reason, but if the person has a super tight anterior deltoid and pec, are they going to be able to get this arm up and behind their head easily? No matter how many times I go through this motion and teach range of motion and all, no, what has to happen? You have to elongate this muscle. You've got to get those fibers to relax and allow for the movement. So this applies everywhere, and there's lots going on inside of our pelvis. So we've got to teach people the difference between relaxation and activation. And it's going to be different for each person. So a pelvic floor therapist they do internal exams. They're specially trained to do that. They can feel and palpate the spasticity of a muscle, the tone of a muscle, the ability of that muscle to contract and relax. That is not what we're doing in home care. But you can at least give your patient some tools to become more aware on their own and work on this a little bit. Are you going to spend an entire therapy session on it? Probably not. But if you can hit on it a little bit, build it into their home exercise program, you're going to make a really big difference for this patient. You're going to find that they're telling you that they've had to change their depends less frequently, that they have been less incontinent overnight, and that they feel less anxious about going to the bathroom. And those are huge, huge, huge. So if we want to get to like the Medicare standpoint and how this reflects in billing and documentation and is it relevant to occupational therapy, it most definitely is. You just have to know your place in it, and you need to have confidence in it. And that's a really, really important thing. So just don't lose sight of that, and remember that occupational therapy needs to kind of, we shouldn't still be fighting for our role in a person's plan of care. But if you find that you are needing to justify and look for ways to work with a patient, let's not forget about incontinence. Stress incontinence is a big one. Flat out, full on incontinence where people have no ability. Is there hope for them? Maybe, maybe not. I'm not a specialist, but you cannot hurt by trying and putting it through in your plan of care. And these are very effective things. So educate yourselves, maybe pick up a balance disc that I showed you. There's a lot of different ones available online. Start doing some of the exercises yourself so you can feel what's going on there, so you can demonstrate them to your patients, and be an advocate for OT and our role in doing different types of exercises that pertain to functional tasks. And in this case, it's toileting, right? Toileting, hygiene, it's an ADL of self-care. Because if a person's incontinent all the time, what should they be doing? They should be washing that area, not just wiping it. It should be washed with soap and water twice a day if they are fully incontinent and it depends. Do you know how many people do that? I would say less than 1%. So again, I've talked about urinary tract infection risks and all these things. So you can be making a difference in minimizing falls, stress, which is good for, anybody's emotional state, hygiene, decreasing risk for urinary tract infection, and overall improving quality of life. And that's what we're all about. So let's not forget about those things. And I will be putting the links in the notes and the show notes, and as well below the YouTube video here on the online course that I took, some other information regarding pelvic floor. And I encourage you to get out there and learn more about it so that you can bring this to your patients. And don't be afraid to tell them, I'm not a specialist in this. I'm learning as I go. Here are some tools. Do you want to work on this with me and give me your feedback? I'd really appreciate it. You could be helping me to help other patients, right? Don't think that you have to be an expert or tell people you're an expert at it. Just tell them, I'm learning about this stuff. You want to help me? let them be a partner with you. It's really exciting. That's what I did when I first started doing it. And it really encouraged people to share honestly with me what was happening and how they felt and what changes they saw. So let's do that for each other and for our patients. And I'm excited to see what happens here with everybody's outcomes. Maybe you'll leave me a comment and let me know months down the road what you found and how your patients are responding. So thanks for tuning in, and stay safe and healthy out there.